The American Psychiatric Association is a leading professional organization for psychiatrists in the United States. One of the APA's most important contributions is the development of clinical practice guidelines. These guidelines provide evidence-based recommendations for diagnosing and treating mental disorders. They are designed to help clinicians make informed decisions about patient care. They are periodically updated to reflect the latest scientific advancements and changes in clinical practice. By providing clear and concise recommendations, the guidelines help to standardize care and improve patient outcomes.
Major depressive disorder is a common and serious mental illness characterized by persistent sadness, loss of interest, and a range of emotional and physical symptoms. MDD can significantly impair an individual's ability to function in daily life. Core symptoms of MDD that should be present for 2 weeks: depressed mood most of the day, nearly every day, and anhedonia, and 3 to 4 of the following: significant weight loss or gain or changes in appetite, insomnia or hypersomnia, psychomotor agitation or retardation observed by others, fatigue or loss of energy, feelings of worthlessness or excessive guilt, difficulty focusing or concentrating, recurrent thoughts of death, suicidal ideation or suicide attempts.
The APA guidelines recommend a combination of medication, psychotherapy, and lifestyle changes for treating major depressive disorder. The specific treatment plan will vary depending on the individual patient's needs and preferences.
Treatment is divided into 3 key phases, each with specific goals and strategies. During the acute phase, the goal is to achieve remission. The duration is typically 6 to 12 weeks. Treatment options include pharmacotherapy. Antidepressants such as SSRIs, SNRIs, or other classes are used based on patient needs and tolerability. Psychotherapy such as cognitive behavioral therapy, interpersonal therapy, or a combination of therapy is recommended. Other somatic therapies such as electroconvulsive therapy for severe or treatment-resistant depression. Frequent monitoring and follow-ups are needed to assess response and adjust treatment.
In the continuation phase, the goal is to prevent relapse and consolidate remission. Duration for treatment is about 4 to 9 months following the acute phase. Treatment strategies are focused on continuing the effective treatment regimen from the acute phase, monitoring for residual symptoms and side effects, and encouraging treatment adherence.
In the maintenance phase, the goal is to prevent recurrence of future depressive episodes. Treatment approach is the long-term use of antidepressants for high-risk individuals. Psychotherapy supports coping strategies and lifestyle adjustments. Regular monitoring can detect early signs of recurrence.
The effectiveness of antidepressants is similar across classes, that is, SSRIs, SNRIs, bupropion, TCAs, MAOIs. Medication choice should consider patient preference, past treatment response, safety, tolerability, medical conditions, pharmacological factors, and cost. SSRIs, SNRIs, mirtazapine, or bupropion are typically recommended, while MAOIs are reserved for treatment-resistant cases.
When transitioning to or from an MAOI, a washout period is important to avoid serotonin syndrome, a potentially fatal condition. Antidepressant doses should be gradually increased to a therapeutic level as tolerated, which may take weeks depending on side effects, age, and medical conditions. Initial improvements may be noticed within 1 to 2 weeks, with full benefits likely by 4 to 8 weeks. Since some antidepressants, like TCAs, can be lethal in overdose, small quantities should be dispensed early on, especially for suicidal patients. Safer options, such as SSRIs, are preferable in such cases.
ECT is one of the most effective antidepressant treatments, with 70 to 90% of patients showing improvement. Precautions should be taken for those with recent myocardial infarction, arrhythmias, or intracranial lesions. Temporary cognitive effects like confusion, lasting 30 to 60 minutes, and retrograde amnesia may occur but typically resolve. Treatments are given 2 to 3 times weekly, with a course consisting of 6 to 12 sessions until symptoms improve or stabilize.
Depression-focused therapies include CBT, interpersonal psychotherapy, problem-solving therapy, and as an alternative, psychodynamic psychotherapy. There is growing evidence supporting the use of technology-assisted therapy, such as online cognitive behavioral therapy, as an effective treatment option.
Treatment should continue for 4 to 8 weeks before assessing responsiveness. If there's no improvement after 1 month, modify the plan. For less than moderate response, evaluate diagnosis, side effects, co-occurring conditions, psychosocial factors, therapeutic alliance, and adherence. Adjust medication or psychotherapy as needed. If minimal progress is seen after 4 to 8 weeks, conduct another review and consider consultation.
Addressing an inadequate response involves maximizing initial treatment. Increasing the dose of the antidepressant is a reasonable first step if side effects are manageable and the maximum dosage has not been reached. Some patients may require doses exceeding FDA-approved limits. For partial responders, especially those with personality disorders or significant psychosocial stressors, extending the medication trial by 4 to 8 weeks may be considered, but not indefinitely.
If an initial antidepressant yields no partial response, switching to another non-MAOI antidepressant within the same class, such as SSRI to SSRI, or a different class like an SSRI to TCA, is a common strategy. For those able to adhere to dietary and medication restrictions, a non-selective MAOI can be used after an adequate washout period. Transdermal selegiline is another potential option. Evidence suggests that quetiapine monotherapy is effective, though its side effects should be carefully considered. Combining pharmacotherapy with psychotherapy can be more effective than either approach alone, especially for patients with chronic, severe, or complex depression. For mild to moderate cases, benefits may be less pronounced. Augmentation strategies for antidepressants include adding another non-MAOI antidepressant, generally from a different class, adding lithium, adding thyroid hormone, adding a second-generation antipsychotic. Less evidence-supported augmentation options include adding an anticonvulsant, omega-3 fatty acids, folate, or a psychostimulant like modafinil. For anxiety or insomnia, include an anxiolytic or sedative hypnotic such as buspirone, benzodiazepines, or GABA agonists like zolpidem or ezopiclone.
Standards are based on clinical data for each individual and may evolve with advancements in knowledge and practice. Treatment guidelines are recommendations, not guarantees of success, and do not encompass all possible methods of care. The final decision on treatment should be made by the healthcare provider, considering the patient's specific clinical data and available options. Follow our practice guidelines series on www.advancedpractice.io.